Hello. I'm discussing the SDL titled Congenital Heart Disease 1. Now, septal defects are the most common presentations of congenital heart disease. Ventricular septal defects account for about 4 in 10 presentations, and atrial septal defects for another 1 in 10. So combined, half of all congenital heart defects are septal defects. This is involved with a shunting or a spillage of blood from one side of the heart into the other. And septal defects are typically going to be left to right shunts. The tetralogy of Fallot is a very complex disorder characterized by pulmonary hypertension and stenosis of the pulmonic valve. That's a right to left defect. So the most commons are left to right shunts, VSDs and ASDs, and for a right to left shunt, tetralogy of Fallot. The direction of shunting really characterizes the symptoms that we see in different manifestations of congenital heart disease. And the shunts are anatomical in origin. And so that's where we start off, is by understanding the concept of a left to right and a right to left shunt. A left to right shunt is a spilling of blood from the left side of the heart back into the right side of the heart, a little bit and a little bit and a little bit with every beat. And what happens as a result of this is that the right side of the heart gets volume overloaded, because it's getting all of the volume it normally receives from the right atrium, but it's also receiving a little bit extra from the left ventricle that it shouldn't be because of the hole in the septum. And this can be a hole in the atrial or the ventricular septum. They're both going to cause a left to right shunt because the pressures in the left side of the heart are greater than the pressures in the right side of the heart. Remember that blood returning to the left side of the heart from the pulmonary circuit has already been pumped by the right ventricle. And that's where it got all of that pressure to begin with, is from the right ventricle's contraction. But blood entering the right side of the heart has been all the way around the diastolic loop, all the way around the periphery of the body. And it has not been pumped in a long time. So normally that's going to be a low pressure zone of blood versus the high pressure zone of the left side. So if you have a hole in the middle of your heart, standard, you're thinking it's going to go left to right normally. A right to left shunt is quite peculiar because it's going in a direction that you would not expect it to be going. And whenever blood goes right to left, what we see is a left heart volume overload, because blood's going, it's bypassing the pulmonary circuit and entering the systemic circuit. So what we see here is a cyanosis, because there's blue blood entering what should be a purely red circulation, kind of making it purple, you know? And this is in contrast to the general hypoxia that we see in a left to right shunt. Now, in a left to right shunt, you don't pump purple blood out to the body because the blood, it's already been to the lungs. The problem is in a left to right shunt, it just keeps going back into the lungs. Versus with a right to left shunt, the blood never goes to the lungs in the first place. It totally bypasses it. And that's generally speaking, and there are exceptions to this, and we'll see it. Right to left shunting is typically going to be a diagnosis of signs. There will be very specific things that you see on a patient, you observe, that lets you know a right to left shunt is occurring. And the number one sign is cyanosis, specifically truncally cyanosis. You know, you get cyanosis in your hands, your feet. Well, that could be a lot of things, you know, but you get cyanosis in your trunks and you know it's a heart problem because you're not pumping enough blood to these organs. Also, you can see clubbing of the nail beds of the digits. That means the fingers and toes. And there are many proposed mechanisms for why this clubbing occurs. And it's not really been fully elucidated yet, so it's not in this SDL. And then finally, a right to left shunt is going to present with a volume overload on the right heart, leading to a volume overload in the pulmonary circulation, which means that these patients are going to be tachypnic. They're going to have an elevated breathing rate. And you see that right here. The patient increases their minute ventilation to blow off excess carbon dioxide. And then the third category of congenital heart disease that we have is the obstruction. And that makes a lot of sense. You know, something's in the way of the blood flow. So you're going to see an increased afterload, and you're probably going to see a murmur because of the turbulence. So that's very simple. Let's get into the atrial septal defect. I suppose it's first because we're going in alphabetical order. What you need to know is that these are 10% of all congenital heart diseases, and it is the second most common left to right shunt behind the ventricular septal defect. This page really deals with the anatomy, and once you understand it, it's pretty easy to remember. You have one septum when your heart is still a big open cavity. You have one septum that's going to drop straight down to begin with, and that's called your septum primum. And as the septum primum approaches the endocardial cushions, which is like a point in the middle of your heart, there's going to be a distance or a gap in between that septum and the cushion. And that gap is called the ostium primum. Now that can be patent, meaning that can be still intact when you're born, but usually that fuses on up. So after the septum primum descends, there kind of becomes some perforations in the apical part of the septum primum, and that's where the ostium secundum forms. The ostium secundum is going to be that hole at the top of the atrial septum, and that can also be patent if the septum secundum fails to form. Now, when the septum secundum drops down, it's going to kind of align with the septum primum, but there will still be a potential space in between these two septums. And that space is called the foramen ovale. And the reason there's a space in between them is so that blood from the fetal circulation can go through the wall of the right atria as it comes up from the ductus venosus and bypasses the liver and runs up the IVC. It's going to shoot through that foramen ovale like with the same angle or the same arc that water flows out of a water fountain. It looks just like that. So that's why you have these septums to begin with, is because blood coming upwards from the IVC needs to get out to systemic circulation by bypassing the lungs. So a foramen ovale is totally normal. It's not an atrial septal defect. That's a big point. A foramen ovale is not technically an atrial septal defect. What are atrial septal defects? Well, the ostium secundum defect, as we saw right here at the top of that septum, is the most common. It's going to be 3 out of every 4 atrial septal defects, and it's really located in the center of the septum. This image on page 5 gives you a good view of the ostium secundum and the ostium primum, and really those are the only two that you need to be able to differentiate. Because the sinus venosus defect, if you know what the sinus venosus is, you know that it's going to be a hole where you see the SVC and IVC popping into the right atrium. If you know what the coronary sinus is, well, that's the veins that bring blood back from your heart muscle to your right atrium. Then you know that a coronary sinus defect is going to be where those veins enter the right atrium. So you're going to be able to understand that question if it's presented to you in both words and pictures. But an ostium primum versus secundum, you need to know that an ostium primum defect is going to be closer to the ventricles. So it's going to involve the AV valves more often than an ostium secundum defect. Finally, there's this atrial defect called the common atrium, which we will get back to that at the end of this lecture because there's a different pathology that looks very similar to it. So all atrial septal defects initially present with left to right shunting. Why is that? Because the blood coming back from the pulmonic circuit is a higher pressure than the blood entering the right side from the systemic circuit. And so because things diffuse from high to low gradients, be it a liquid or, osmosis, anything goes from high concentration to low concentration. So that's the direction that blood is going to move passively through this hole in the heart. And what you're going to see is that over time, the right side of the heart is going to become volume overloaded. And in an atrial septal defect, it's going to be both the right atrium and the right ventricle, because blood goes first into the right atrium, then the right ventricle. Now, atrial septal defects can often be asymptomatic, and then they'll present in adulthood as the effects of that shunt compound over time and gradually stress the pulmonic circuit even more and even more with age. If the hole is big enough, however, the defect will be symptomatic in infancy, and it will present as a failure to thrive. And the reason I've got failure to thrive underlined is because we see this term quite often, and I didn't quite understand that the reason that we see this term so often is because it's actually a diagnosis. It's an ISD. And so that means that when we say failure to thrive, we're referring to a low height and weight percentile for the patient. And it's referred to so often so that we can standardize our communication, so that when I say failure to thrive and you say failure to thrive, there's no ambiguity about it. It's a diagnosis. So that's a little tidbit there. You're going to see with an atrial septal defect a wide S2 split with a fixed interval. And the reason why the interval is going to be fixed with a large atrial septal defect is because the ventricle is so volume overloaded that it never clears out all of the blood inside of it. And remember, normally, first you're going to hear your aortic S2, and then you're going to hear your pulmonic S2. And the reason for that is because, well, whenever you're breathing in, your lungs are inherently a higher pressure circuit than your system, because you've got your veins down low in your feet, and then you've got your belly, and blood goes from your thorax, from your aorta specifically, to those low pressure areas very easily. So because blood goes to those low pressure areas more easily, it goes there faster. But the lungs are a bit higher pressure than the rest of your body, just a little bit, marginally. But it's enough so to mean that blood enters your pulmonic circuit more slowly than it enters your systemic circuit, because it has to overcome a little bit higher pressure pumping against itself in order to move into the lungs and inhabit that space. So whenever you have a volume overload on your right heart, as you would see in your atrial septal defect, you can expect a widely split and consistently split P2, which means that it's not going to vary with inhalation or exhalation. And the reason it's not going to vary is because it would vary if the right ventricle pumped out all of its blood every single contraction. But because the right ventricle is volume overloaded, it's just getting out as much as it can. It's getting out 90% of what it should be getting. And so because it's getting out a sub-maximal output every single beat, the distance between the A2 and the P2 is going to be constant, because the right ventricle is pumping as much as it can per beat. There's no variation. It's volume overloaded. There's no variation in the output of the right ventricle, so it's a fixed splitting. And it's widely split because, again, the right side is volume overloaded, so the pulmonic circuit is volume overloaded. So blood has to push harder to get into the lungs. So because it has to push harder, that P2 is more delayed than it would be in a normal person. You're also going to hear a systolic murmur at the second left intercostal space, and we know that that's going to correspond to the pulmonic valve. If it were at the right intercostal space, that would correspond to the aortic valve, but a pulmonic valve murmur makes sense if we're talking about right heart problems. You're also going to hear a murmur during diastole, and that's going to be at the lower left sternal border, corresponding to where you hear flow across the tricuspid valve. And you need to be able to picture these spaces just instantaneously, because they will be in question stems across a great number of classes. They will be on your boards. You will use them for the rest of your life. Learn the locations of these 4 heart sounds as soon as possible. On a radiography, we're going to see a right heart enlargement, and this is often described as a prominent margin or a prominent border if they don't show you a picture of it in a question stem. If they do show you a picture of it in the question stem, you know that the lungs are going to be dark on an x-ray because there's nothing in them. And so that margin or border of the right heart is going to be very contrasted to those dark lungs in an x-ray in which there's right heart hypertrophy, and the hypertrophy will immediately account for the greater density on a radiograph. And that can apply to the pulmonary artery too, right? Because when you have a right ventricular hypertrophy, well, sooner or later, you're gonna get pulmonary hypertension. And so that manifests as a greater density of that tissue as it undergoes hypertrophy, hyperplasia, and fibrous deposition over time. It gets denser and denser and denser on radiographs. So there's a basis for how you can hear these things described in the question stem. And then going on, we diagnose septal defects by a heart cath. A heart catheter is a very good clinical tool. It can tell us lots of things. It can tell us the oxygen pressure of the blood within a given chamber of the heart. And in diagnostics, that's very useful because we know what normal is. Normal is going to be 75% on the right heart and 95% on the left heart. You should really remember those O2 sat numbers because everything can be compared to them. As you see on the right image, whenever you've got this left or right shunt, the O2 sat of the right heart goes up from 75% to 85%. So that increased oxygen pressure, right, is what immediately accounts for the right-sided, then pulmonic hypertrophy. As we said, the degree of symptoms experienced by a patient is proportionate to the whole of the heart, the septal defect, the size of the septal defect. And many of them are so small to where they don't immediately present in infancy or even childhood. They do present in the adult population, though. They'll present in the second to third decade with children with large septal defects, and in the fourth to fifth decade with people whose septal defects were never caught. And when they present in the adult population, there's one side effect that you need to be acutely aware of, and that's the paradoxical embolus. This is a very frequently tested concept. And you can get a paradoxical embolism, which is an embolism that arises from your systemic circuit but bypasses the lungs to go to your brain. You can get one of these whenever there is a transient flow reversal. So the shunt will, in a split second, go from left to right to left. And I'm going to explain to you why that happens. Whenever you exert against pressure, you perform the Valsalva maneuver. So side note, you need to know what the Valsalva maneuver is. What the Valsalva maneuver is, you close your airways and you try to breathe out. So you go, and when you do that, pressure builds up inside your thoracic cavity. Now, when pressure builds up inside your thoracic cavity, the blood that is supposed to be returning to the right side of your heart via the superior vena cava and the inferior vena cava, it doesn't want to go into your thoracic cavity because that's really low pressure venous blood. So when you're holding your breath, you know, when you're popping that squat up, getting 300 off the rack, whenever you're doing that bench press, whenever you're finishing that marathon, whenever you're doing anything in which you hold your breath, you are increasing the pressure within that box of your thoracic cavity containing your heart and your lungs. And specifically, when you inhale and you hold it, the volume of your lungs is going up, 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 but the volume of everything else is staying the same. So your heart's getting marginally compressed by your expanding lungs. And when this happens, it is harder to push blood into the right atrium because that blood is coming from your venous system and it's not high pressure at all to start with. And it doesn't want to go into that high pressure right heart, especially not when you're holding your breath. You can't make it go in there. So it stays outside of the thoracic cavity. And it waits, and it waits, and it expands your SVC, and it expands your IVC. And it waits for you to exhale and decrease the pressure in the right side of that heart, right? So that the blood can enter. And when you exhale, all that blood that has been pooling in your veins, waiting for its chance to enter the heart, does so at the same time. So your right atrium receives a transient spike in pressure. And it'll go from 75 O2 sat, 75% to like 82%. You know, the pressure in it builds up to the point where it reverses the shunt. It reaches a greater pressure even than the left side of the heart. And it's all due to the sudden return of blood at once to the right atrium from the superior and inferior vena cava. So that's how you get a shunt reversal. That's how you get a paradoxical embolism whenever a clot gets carried through that hole by that transient flow reversal. So a paradoxical embolus is a very bad consequence. Obviously, it presents acutely, and it can be kind of the warning sign that a patient does have a septal defect that they did not know about. Some other symptoms listed here are, I didn't highlight because they're fairly obvious. You see a right-sided congestive heart failure, as you would expect, as that right ventricle hypertrophied and became more and more scarred. You would see a pulmonary vascular obstructive disease, and it's going to be an obstructive disease because what's obstructing air from perfusing into your blood is fibrosis, as the hypertension in that pulmonary system accumulates and makes those vessels thicker and vasoconstricts them. And then you're going to see atrial arrhythmias, with an atrial septal defect because, of course, the blood's going from your left side into your right atrium, and it's going to stretch that tissue. And as it stretches, the conduction pathways embedded within the walls of that atria also get stretched. So you can see a conduction deficit presenting as an arrhythmia in an atrial septal defect. If they're small, you don't have to operate on them. If they're large, you need to operate on them. And small versus large is measured by the pulmonic flow versus systemic flow. And it can also be characterized by echocardiogram. Let's get on to the ventricular septal defects. The VSD constitutes 42% of all cardiac malformations at birth, and it's due to deficiencies in the formation of the ventricular septum, which separates the two ventricles in the bottom half of the heart. Now, this is not as complex as it seems upon first pass, but if you don't know the terms endocardial cushion and conotruncal ridges of the truncus arteriosus, you ought to take 5 or 10 minutes now and go look those terms up to understand what they are and be able to visualize them in the heart. Using words, I would tell you that the endocardial cushions are kind of the dead center of the heart. If you just drew a Y and an X axis and you popped a dot at the origin, that's where the endocardial cushions are. The conotruncal ridges and the truncus arteriosus. So if you're thinking about that dot, that's the origin of the two axes, then the truncus arteriosus is just going straight up on the Y-axis. And the truncus arteriosus is the name for the common arterial trunk. That is the first structure to rise upwards out of the heart. And then it will split into your aorta and your pulmonary artery. But as it splits, it twists and it separates. And the reason why it separates is because there's a septum that grows in the middle of this tube. Kind of like here's the tube, you get the septum growing in the middle of it. The tube is the truncus arteriosus, and the septum is growing from the conotruncal ridges. So it'll twist, and by virtue of the septum, it will separate into two vessels, the aorta and the pulmonary artery. That's what's going on there. Ventricular septal defects, back to that. You've got membranous ventricular septal defects and perimembranous ventricular septal defects, and they are characterized by their histology. Membranous obviously are membranous in nature. They're formed from mesenchymal cells, and perimembranous are going to be more fibrous. They're going to be your fibroblasts and smooth muscle cells that there's a defect in order to get this perimembranous septal defect. The membranous ventricular septal defects are by far the most common, 3 out of 4, 4 out of 5. And where they're located is immediately underneath the left ventricular outflow tract, just below the aortic valve. And this corresponds to where I've labeled A on this diagram on the right here. So that's the big boy. That's the one you need to be able to recognize if she gives you a picture with a hole in the ventricle, only one hole immediately under the outflow valve. Then you know it's going to be a membranous ventricular septal defect. B, C, and D, the subpulmonary, the muscular, and the endocardial cushion defects, those are less common. I've labeled them here on these, this image. And C is the one, the muscular defect that can present as the Swiss cheese septal defect. I don't know what she could ask us about that, honestly. And it's kind of unfair to give us a gross image of a heart with a hole in it, considered we haven't been able to get into a lab and see the inside of a heart from continuous angles, you know. So if she does do that, it's only going to be one question, just grin and bear it, you know. But I think that that's a really weird thing to test, because a septal defect is a septal defect, you know. And the reason why I think it's weird is because we'll see later that, well, as in the atria, the degree of symptoms is proportionate to the size of the defect, not the location. So when you have a ventricular septal defect, what you see is left to right shunting. Again, the right heart's going to be volume overloaded. Again, the right heart's going to be putting all that blood into the pulmonary circuit. Again, but you're also going to get a left ventricular hypertrophy. And you're going to get a left ventricular hypertrophy because there's an increased volume load on them as well. In fact, your whole heart's under an increased load. Why? Because you're not moving blood out of the pulmonary circuit. And if it stays stuck in the pulmonary circuit, well, it just goes straight out the right ventricle, comes back to the left ventricle every single time. You can't get rid of maybe, 10% of blood per beat because you're shunting it over. That's really not good. You see a decreased systemic cardiac output manifesting as a mild, consistent, persistent, chronic, it's always there, hypoxia. So if you have a ventricular septal defect, you're always a little bit hypoperfused across all your organs. And so the response to this, well, your body thinks that you're hypovolemic, Your body thinks that you literally don't have enough blood volume. And the truth is you don't, not in your systemic circuit, because it's all tied up in your lungs, because you're spilling it back over into your lungs from the left side of your heart through this hole in your ventricular septum. So what your body does in response to this simulated hypovolemia is it increases adrenal production of catecholamines because it needs to get your blood volume up. And how it knows to do that is by sending out epinephrine to bind alpha-1s to constrict your venous and arterial beds. And how it also does that is by telling your kidneys, hey, we need more renin, which means we need more angiotensin, which means we need more aldosterone, which means we need to get this dude's blood pressure up because he's hypoxic. So how this presents is you'll see a 10-year-old, a 14-year-old, 16-year-old, and they're going to have a blood pressure like 160 over 110, or maybe like 155 over 95. And you ought to be suspicious, because it won't go down. And you'll see them over and over and over again. Maybe you're their primary care doctor. Maybe you're the ED doctor and they're presenting with hypertensive urgency/emergency at the age of 14. And you're like, why does this kid have such high blood pressure? You need to be thinking of a septal defect that would have their catecholamines and their hormones consistently through the roof in order to raise blood pressure. So you'll see a pulmonary congestion with this as well, because again, there's so much blood going through the pulmonary circuit that eventually the hydrostatic pressure within those pulmonary arteries and veins it keeps going up, it keeps going up, it keeps going up. So it's going to push that fluid out into the tissue, into the interstitium of the alveoli of the lungs. Anytime you see pulmonary congestion, that's what's going on. The functional parenchyma of the lungs, the alveoli, are just being drowned. And they're being drowned because there's so much blood flow to the lungs that it just gets pushed by force into the tissue of the lungs instead of staying in the bloodstream like good blood should. So when the lungs get congested and the lungs develop hypertrophy, what happens is that the right side of the heart has to pump more and more and harder to compensate, to push blood through this continually stenosing pulmonary circuit. And what happens whenever your right side of the heart hypertrophies in a left to right shunt is that the pressure in the right side of the heart will eventually overtake the pressure on the left side of the heart. And that's called Eisenmenger. And that's the worst case scenario for a left to right shunt. Eisenmenger syndrome is a shunt reversal, and you're going to recognize it because the patient will get acutely cyanotic because all of a sudden the shunt will be going right to left and they'll be putting blue blood into red circulation, giving you purple all over the body, and they're going to be cyanotic. So going into a VSD, the bottom of page 9 here is kind of where it mentions that clinical manifestations are determined by the size of the shunt, and the location of the VSD is irrelevant in terms of the degree of the shunt. So use that to guide your studying. Small defects present with a hollow systolic murmur, which is the same thing as a pansystolic murmur, which means that for the entire duration of systole, you're hearing a heart sound. The reason you're hearing a heart sound throughout all of systole is because whenever the ventricle is contracting, some of that blood is getting spilled into the other ventricle. And so there's turbulence, and so there's like some splashing of blood that gets produced whenever you push blood from one ventricle into another, and you're going to hear that. And it's going to be present throughout all of systole. That's going to characterize small and mid-size atrial septal defects. The mid-size defect is when you start seeing symptoms present, and something Relatively mild, but that can get severe, is frequent respiratory infection engendered by pulmonary congestion. And remember, we said that pulmonary congestion is basically when the parenchyma of your lungs gets soggy. The interstitium just gets filled with fluid because the hydrostatic pressure in your pulmonary circuit becomes so elevated that it just pushes blood into the lungs. It's got to go somewhere. The fluid has to go somewhere. And so as long as the shunt's there, it just keeps getting worse. So that can result in kind of a boggy environment inside your lungs. And, I don't know every step of the biochemistry behind it, but you just got to think about it. If you've got soggy lungs, do you think bacteria are going to get up in there and have a party? Yeah, boy, you better believe it. They're going to love it in there. They're going to set up shop in there. So that's why frequent respiratory infections accompany these septal defects that cause you to have boggy lungs. A large defect will present with really bad symptoms, and large defects typically present in the first few weeks of life as congestive heart failure and failure to thrive. It's going to be, the parent will bring them in for a well child visit, and they're like, "Doc, something is wrong with my child. They've really rapidly gone downhill." And you're going to have a high suspicion for a heart defect when it's that soon in their lifespan. You're going to listen to their heart and you're not going to hear a murmur. Why are you not going to hear a murmur? Because the hole in the heart is so large that there's like basically no turbulence there, The flow is good. It's so large of a hole that the flow is going to be fairly laminar through it. It's like, man, that's a big defect. You're going to see irreversible pulmonary vascular disease secondary to this hypertension of the pulmonary circuit and this congestion we've been referring to. And you can see Eisenmenger syndrome present quite rapidly in these infants and children with large ventricular septal defects. On a radiograph, the whole heart's going to be a little bit bigger. You may see the pulmonary arteries be a little bit more prominent. That's the buzzword there, or a little bit more, I don't know, radiopaque, that's the word for it. If you see a picture of it, always make sure, start with the border of the heart, trace it, see if one side's larger than the other, then immediately go onto the pulmonary artery and the aorta and see what's going on with those, because if one of those is really wider than the other, it's going to reflect that there is a hypertrophy of the walls of the aorta or the pulmonary circuit. Heart cath, going back up, remember that 75% is normal on the right side, 95% O2 sat is normal on the left side. If anything is above or below that on either side, it's pathologic. Most small ventricular septal defects are going to close. We don't have to operate to treat them. We don't even have to give medications to treat many of them, although we can supplement with kind of some things to manage the symptoms. We can give them a diuretic to relieve the congestion and the fluid in their lungs, or we can give them a beta blocker to get their heart working a little bit less hard, reduce the O2 demand on it. But really, we're going to be treating the symptoms with the drugs that we use, and the hole itself is going to heal on its own. Now, surgery is indicated if it's a really large hole, as measured by the QPQS or by echocardiogram. Or if they have recurrent pulmonary infections, as we said, that's going to be due to the fluid accumulating in the lungs due to pulmonary hypertension. Moving on to the patent foramen ovale. Patent foramen ovale is normal. And if we go back up to this chart here, discussing the relative frequency, you notice the patent foramen ovale is not on there. And that's because the foramen ovale is patent in everybody at birth. In you, it was open whenever you were born, and it closed. Why did it close? Well, because the pressure in the left atria went way up, and the pressure in the atria, the left atria specifically right here, went up because you started breathing. So about 1/4 of individuals have a patent foramen ovale. The patent foramen ovale is susceptible to the paradoxical embolus by means of transient flow reversal that we talked about with the atrial septal defect. Remember, we said that whenever you hold your breath, you increase the pressure in your thoracic cage. And whenever you do that, venous blood doesn't want to move into your thorax because that's a high pressure system. and venous blood is really low pressure. So when you let that breath out, all that venous blood goes back into your right atrium at the same time, and it's going to generate enough of a force to push that foramen ovale open and spill over a little bit into the other side. That's how you can get a paradoxical embolus with a patent foramen ovale. The other major complication of a PFO is a migraine with aura. I don't know. I didn't highlight anything there because it's just like, okay, know that patent foramen ovale patients present with migraines, severe migraines. It's like, okay, and they'll have auras too. That's another thing. So treatment options vary. We can treat it pharmacologically. I'm sure that we'll have a lecture on that. Moving on to the patent ductus arteriosus. Remember that the ductus arteriosus is going to be the mechanism of bypass of the pulmonary circuitry in the neonate. The fetus wants to bypass the lungs because it's sitting in a bunch of fluid. What's it going to breathe? You know, nothing. Well, it's going to breathe liquid? No, it's not going to do that. So you bypass with this ductus arteriosus, right? And whenever it remains open after the kid starts breathing, it's called a patent ductus arteriosus. And you're born with a patent ductus arteriosus, but it closes in about 2 days of birth because of prostaglandin E2. And when it doesn't close, we need to close it because really bad things can happen. Now, a patent ductus arteriosus that won't close is associated with maternal rubella, which we don't really see a lot in America. You'll probably not see it that much on your rotations, but if you go to another country, rubella is still a thing. Remember, rubella is going to be a RNA virus. It's RNA positive. The mom is going to present with a descending rash. It gets worse, possibly a fever, and arthritis is also associated with rubella. PDA is also associated with prematurity because, again, you need the lungs to be fully functioning in order to induce the closure, the prostaglandin-mediated closure of that patent ductus. So if your lungs aren't functioning, you're not getting the oxygen that is supposed to raise the concentration of these prostaglandins that is supposed to close this ductus arteriosus. So here I've kind of labeled how the shunt works. The shunt is only spilling into the pulmonary artery. And this is a left or right shunt, but it has nothing to do with the right atrium or the right ventricle. It's only the pulmonary artery at first that's going to get blood deposited back into it from the aorta. What that means is that there's a volume overload of the lungs. And what that leads to is a volume overload of the left ventricle, because it's got to hold all the blood coming back from the lungs, you know. So if there's more blood going through the lungs, well, then there's more blood that the left ventricle has to manage. So the left ventricle can pump and pump and pump and pump and pump. And you'll see a prominent left ventricular murmur. I kind of annotated it on the right here to let you know that because of the buildup in pulmonary pressure, you can get a pulmonary hypertension in the long term as a result of the patent ductus. And this can lead to a compensatory right ventricular hypertrophy because it's got to work harder, because it's got an increased afterload, as we know by the constriction of pulmonary vessels. So you can get a right heart hypertrophy, which means the pressure in the right heart can build up enough to where you could get Eisenmenger syndrome from this, which means that the shunt would then be going right to left. Meaning that it would then present as a cyanosis because you'd be shooting blue blood up and through this patent ductus arteriosus, and you'd be mixing with the red blood of the aorta, and you'd have a purple body. But depending on the location of the shunt, you might only see it in the lower extremities. And we're going to go down and let's see. Never mind, it's not in here. I was thinking about something different. I was thinking about coarctation, yeah. So the same thing can happen where because your subclavians pop off above the shunt, you're not going to get cyanosis in your hands, but you will get cyanosis in your feet. So if you ever see differential cyanosis only in the lower extremities in a patient and you're suspecting a heart defect, well, then it could be this, the patent ductus, or it could be a coarctation. So that's a small little differential right there. A PDA presents with a machinery murmur. What's that mean? It means it's always there. Through all of systole and all of diastole, the heart's just talking away. It's a loud murmur. You're going to hear it in the left infraclavicular area. You're also going to hear it in the back between the shoulder blades because that's where the aortic arch goes. It goes backwards a little bit. And on a radiograph with a patent ductus, you see a prominent main pulmonary artery. Here's the treatment I was referring to with an indomethacin. You basically give them an arachidonic acid metabolism inhibitor. So you want more prostaglandins in order to close that ductus through PGE2 signaling. And then you can treat it operatively in patients with failing left ventricles. The penultimate pathology in this SDL is the partial anomalous pulmonary venous return. And I'm going to skip it because I encourage you to come back and look at this after you look at the total anomalous pulmonary venous return in the next SDL. A partial anomalous pulmonary venous return is basically when less than 4 of the pulmonary veins attach to the superior vena cava instead of to the left atrium. Then finally, we have an Atrioventricular Canal, which is this is the pathology I was referring to earlier when I said something else looked like the common atria. Well, this is it. The difference is that in a common atria, you have no septum whatsoever in between your 2 atria. But with an AV canal, you do kind of have a little bit of a septum on top, as you can see on the left image there. This is a defect in the septum primum, and it's associated with chromosomal abnormalities. So not just Down, but Turner, Pateau, Edwards. If she wants to give you something with a name on it as a syndrome, it's chromosomal abnormality, and AV canal is highly associated with those. You're going to see increased pulmonary blood flow secondary to left to right shunting, and that last sentence kind of ties up this entire SDL. Increased pulmonary flow due to left to right shunting. Thanks for listening.